So we focused on adults who are enrolled in the ACA's Medicaid expansion. So just want to put that up top. And we modeled our analysis on the Limit Save Grow Act, which was a bill passed by the House in 2023. We see that referred to in some of the current proposals. So we think that might be a starting point for current legislation. And that bill would have withheld federal funding for 19 to 55-year-old Medicaid enrollees who didn't work or participate in worker-related activities for 80 hours a month. It did not actually specify only Medicaid expansion enrollees would be included, but it was interpreted that way by a couple of folks, including HHS at the time. But important to note that it didn't actually officially exclude them. And so then we took that information and we analyzed the experience in two states, Arkansas and New Hampshire, that did have work requirements for their expansion populations in 2018 and 2019, and tried to draw on those implementation experiences and try to project what coverage losses would occur under something like the Limit Save Grow Act if the implementation was similar to those experiences in those two states, both in terms of the state implementation and people's reporting patterns. So if we assume that states we're going to follow what those two states did, we estimate that states could automatically identify about half of expansion enrollees 19 to 55 as exempt from or compliant with work requirements using available information they have. So it's really important that the characteristics that people could be reporting on are available in state databases, and then people wouldn't have to report or request an exemption. But among those who wouldn't be automatically exempted or deemed compliant, we estimate 72 to 82% would not be able to satisfy that reporting requirement if the patterns followed those in those two states. So that gets us to the 5 million adults nationally who would lose federally funded Medicaid. So just wanted to kind of lay out some of the caveats. It really does matter what assumptions you use, and coverage losses could certainly be higher if states implemented things in a different way, or lower if they were able to do more of this automating. So the other thing that our study didn't look at directly, but that prior work shows, is that many people are unaware of work requirement policies. And so there's confusion about what's required. There are challenges documenting their activities, submitting proof of their activities to the state. And so it's really a concern to think about the disruptions in healthcare that could occur for a variety of populations that are currently underserved. Certainly, a top concern is adults with chronic health conditions, and really increasing churning of coverage and reducing their access to care across a variety of underserved groups. So we now have two really strong, rigorous studies, one of whom was just published in a journal by a colleague of mine and a former colleague, looking at the experiences in Arkansas. That's the state work requirement that we have the longest experience with. And both studies found that work requirement in Medicaid in Arkansas reduced Medicaid coverage and increased in uninsurance, and that it didn't increase employment rates or enrollment in employer-sponsored insurance. And then there's case study work from other states that supports those conclusions. So we don't have any evidence that would suggest these policies would be associated with increases in employment. And then the other important thing is our findings are similar with those from other research, showing that most people who would be subject to work requirements, in fact, do already work or should be exempt. So in our work, we found that about 9 in 10 adults enrolled in Medicaid expansion in the age group we were looking at, the 19 to 55-year-olds, were already either working some or all months of the year, or are parents or caregivers of minor kids that attend school. They're looking for a job. They're caring for a disabled household member, or they're themselves in fair or poor health or have a functional limitation. So in fact, many who would be at risk of coverage loss are already engaged in the activities that are prescribed by the work requirements that they're intending to promote, or they would meet the exemption criteria. Medicaid is an entitlement program, and so it does not have waiting lists. So whether a child or a senior is going to get enrolled in Medicaid or not really isn't conditional on whether there are other adults enrolled in the program or whether those adults are working. And in fact, states that have adopted Medicaid expansion and expanded coverage for adults actually spend more per capita on those other groups, like children and people with disabilities, than states without Medicaid expansions. So there's not evidence there that those other groups are missing out because of the expansion. And I do a lot of research on coverage of children, and we actually find higher uninsurance rates among kids in non-expansion states than we do in expansion states. So risks of coverage, of not having coverage are in fact higher for kids that have not chosen to expand Medicaid for adults. And then I think it's also important to think about how much kids and people with disabilities and elderly folks benefit when their family members are covered. So if the expansion is not there for them, that could have effects on those other family members. And also having more people in a community with health insurance is also really beneficial for everybody. So, in fact, I saw KFF just put out something today about rural hospitals and how they're struggling across the country, but some of the struggles are larger in the non-expansion states. So a lot of these safety net and other providers really depend on Medicaid funding. So those kids and seniors and people with disabilities also would see benefits from having more adults in their communities having Medicaid relative to being uninsured.